with AMREF Health Africa. And today I'll be taking you through neglected tropical diseases, a highlight, so that we can be able to understand something about NTDs, as we like to call them. And this, of course, is courtesy of the Ministry of Health in partnership with the National Public Health Institute, Kenya Medical Training College, University of Nairobi, National Hospital, and AMREF Health Africa. So I'll give a brief about AMREF Health Africa, which is the largest international NGO in Africa, which has been there for 65 years, which has reached about 70 million people working in about 41 African countries. And African-based, African-led, African-focused, focuses on last-mile delivery and building relationships and partnerships with the local communities, governments, and multiple policymakers. And as I said, it operates over 41 countries in Africa, but also has offices in North America and Europe, which mainly work to do fundraising. And so some of you may know AMREF primarily as the NGO, but we also have AMREF Flying Doctors, which was the inception organization. We also have a fully fledged lab, which has been supporting the government and Ministry of Health, came to prominence during the COVID-19 outbreak. There's also the AMREF International University, which is now a fully fledged university, focused on training the next generation of healthcare workers in public health in the country and beyond. And the Institute for Capacity Building, where we can be able to do online courses to strengthen your capacity in various aspects of leadership, management, M&E, you name it. So we have something called Big Bets. And this Big Bets is an alignment of AMREF Health Africa with the Kenyan government's agenda, the bottom-up economic transformation agenda, the better. And these Big Bets focus on primary healthcare, maternal and newborn health, malaria and climate change, neglected tropical diseases and cholera, and the NCDs, non-communicable diseases. So the reason I'm here today is to talk about the big bet on neglected tropical diseases, which is basically aiming to break the transmission and the elimination of 4 preventive chemotherapy NTDs, mainly soil-transmitted helminths, Mignon, as we commonly know it, bilharzia, or schistosomiasis, lymphatic filariasis or elephantiasis, and trachoma. And so if you've never heard about NTDs, so neglected tropical diseases are a group of 21 diseases. And you can see they range from ectoparasites of scabies. We have protozoa chagas disease found in South America. We have leishmaniasis. We have human African trypanosomiasis. We have viruses such as rabies, dengue, and chikungunya. We have helminths, which I've briefly touched upon, like lymphatic filariasis, soil-transmitted helminths, schistosomiasis, onchocerciasis. A lot of this is onchocerciasis is also commonly known as river blindness, mostly found in West Africa and Central Africa. Our neighbors Uganda also report cases of onchocerciasis, and Kenya is towards the last steps of eliminating onchocerciasis. We also have bacteria caused by leprosy, trachoma, yaws, fungi, mycetoma, and deep mycosis. Snakebite envenoming is also considered a neglected tropical disease. And the latest on the list is one called Norma. So Norma was recently introduced in 2023. It's submission by Nigeria, and it's because it's a disfiguring flesh-eating bacteria that begins from the gum and disfigures the face. And as you can see, these diseases normally don't get prominence, but they do have common interventions that are able to alleviate the suffering of communities and individuals. And this is why they were all classified as neglected tropical diseases about 25 years ago. So in the interest of time, I won't be able to go through all of them. But we do know that, for example, rabies, we have reported cases of rabies in some parts of the country. And some of the initiatives being done are things about mass dog vaccination to be able to reduce the incidence of rabies. Dengue and chikungunya, I'm sure we've seen lots of media outbreaks in the recent couple of years in the coastal part of Kenya, in Mandera, in Wajir. And so the disease epidemiology is spreading, and other research are showing circulating antibodies of this dengue and chikungunya in other parts of the country. And so we have global targets for the elimination of neglected tropical diseases. This is because these are diseases mostly of marginalized and poor communities are most affected. And so we're trying to reduce the suffering of these people. And so guinea worm and yaws are diseases targeted for eradication. In 2024, only 15 cases of human guinea worm have been reported globally. And these were found in our neighbor, South Sudan, and as well as the Central African Republic. And so as you can see, because these are countries that we share close proximity with, especially South Sudan, surveillance has to continue to be able to ensure that guinea worm is eradicated. Some of you may remember a few years ago, seen a lot of posters in your health facility showing a thread-like worm coming from the foot. And if you saw one, we would contact the Ministry of Health, and if found to be guinea worm, there was a cash reward of 100,000. And successfully, though, the country was able to eliminate this in 2017. Other diseases targeted for international transmission as elimination is human African trypanosomiasis, onchocerciasis, leprosy, and to note of these two is that we have two versions of human African trypanosomiasis, gambiense and rhodesiense. So in Kenya, we have the rhodesiense version, which has actually been successfully eliminated last year after multiple years of collaboration between Ministry of Health and various partners. Others aim for elimination are rabies, schistosomiasis, soil-transmitted helminths, trachoma, and rape. And then for control, we have chikungunya, we have dengue, we have cutaneous leishmaniasis, we have noma, snakebite envenoming, mycetoma, scabies, and other entities. So as you can see, there are quite a number of entities, and with the time allocated, I will not be able to go through all of them, but I'll talk about the ones mainly aimed for elimination in Kenya. So we classify them into two main groups: preventive chemotherapy NTDs and non-preventive chemotherapy NTDs. So preventive chemotherapy NTDs are the ones where the common strategy is to conduct mass drug administration, which serves as a prophylactic and preventive approach, as well as treatment. And the diseases targeted for this are lymphatic filariasis, onchocerciasis, schistosomiasis, soil-transmitted helminths, and trachoma. So these five are amenable to mass drug administration, targeting community and school-based platforms, and targets everybody in the community in the area where it's endemic. And you're not required to diagnose each and every single individual before treatment. Usually the classification before treatment comes through surveys that are conducted. And once you are above a certain threshold, then you qualify for multiple rounds of mass drug administration until the prevalence goes down. Then for the rest is individual case management, where we have now the rabies, the leishmaniasis, snake bites, and these occur mostly in health facilities. And this is where clinicians need to be able to be on the lookout to be able to detect and treat these conditions. Not forgetting the PC NTDs, which of course at times we do overlook. And these of course require individual symptomatic diagnosis before treatment. So I'll begin with soil-transmitted helminths, commonly known as STH, which we commonly know as Mignon. And of course, we have three main types: Ascaris, the hookworms, and the trichuris. And these occur commonly in areas where sanitation is poor. And so they are spread through mostly fecal oral contamination or through skin penetration in the case of hookworms. And the adult worms live in the intestines for these conditions. Globally, we find about 1.5 billion people at risk of these diseases, primarily in Southern Africa, Sub-Saharan Africa. And so in Kenya, school-age children between the ages of 5 and 14 have been found to be the most affected. And as you can see, approximately 16 million people, Kenyans, at risk of STH in the country. And looking at the map on the right, you can be able to tell that the prevalence of each species of soil-transmitted helminths differs according to the climatic condition of the area and transmission dynamics. And so we have high pockets in the western part of Kenya along the lake region. You also find northeastern having a lot of trichuris, trichura, and you have the coastal part of Kenya also having trichuris. And so you can see it's very widespread. And so we need to be able to diagnose this from various areas. So schistosomiasis is caused by uh, another parasite called schistosoma, and we have Mansoni and hematobium in our parts of the world. Though in Japan they have a form called Japonicum, and occurs in two main forms of hematobium. I mean, urogenital schistosomiasis and in the intestinal form. There were 240 million people globally affected, 85% of the cases in sub-Saharan Africa. And in Kenya, it's estimated about 6 million people are at risk of this disease, of which 70% are between the ages of 5 and 14 years, which are the school-going children. And going by this map, as you can see on the right, the classification, you can tell that we have very many areas of high endemicity of schistosomiasis, above 10%, some between 2 and 10%, and the yellow being, the light orange being less than 2%, and yellow being 0. So we are aiming to get the entire map of Kenya to the yellow or the first grade of orange, which is where we'll be aiming to interrupt transmission. So these have generic non-signs of symptoms. You have itchy skin, blood in urine, fever, general malaise. In chronic forms, they do present with enlarged liver and spleen. Sometimes you do have lung involvement, diarrhea, weight loss, and poor appetite are common. And these two conditions put together, seen as they mostly affect school-going children, do result in a lot of growth impairment due to sudden growth, and it has been associated with cognitive delays. This is due to enhancement of malnutrition and these children having anemia, and so they have weakness and fatigue. We do know that nutrition status of children in some of these parts of the country are not as good, and so they do develop, it makes them susceptible to other health conditions. A microscopy for these two is mostly done commonly, mostly through stool examination, where you detect the eggs or larva. So you can do either direct wet mount or Catocat's technique. So Catocat's technique is a specialized technique for detecting these eggs, and to be able to, and so you're able to prepare the stool, and you're able to sediment, and you're able to visualize the eggs. For hematobium, the gold standard is urine filtration, where you're able to filter the eggs of S hematobium and be able to read them under a microscope. We do have other antigen tests that are coming up, like it's called POC-CCA. And so in areas where we have prevalence of schistosomiasis below 10%, it becomes quite difficult to detect this in usual wet mounts. So antigen tests are done. And of course, you can do imaging to detect things like schistosomiasis when it causes portal hypertension in very advanced severe cases. So just a reminder of how they look like, as you can see above, how the hookworm, whipworm, and roundworms look like. And you can see how the eggs on the microscope do look like. The hookworm having the clear membrane circular, the whipworm having the terminal mucus plugs, the roundworm being modulated, and S. masoni having a terminal spine, a lateral spine, and the S. hematobium usually has a terminal spine. And so this is how you're able to look at them under a microscope. So at times wet mounts don't do them justice, and so what is why we advocate for Catocat's technique where feasible. So just to bring you up to speed with a form of schistosomiasis called female genital schistosomiasis, it's one of the more neglected diseases amongst condition rather, or manifestation. And this happens where parasite eggs get trapped in the female reproductive organs, resulting in a lot of inflammation and damage. And so symptoms include vaginal discharge, blood in urine, pelvic pain, painful intercourse, and genital lesions and ulcers. And commonly, this is misdiagnosed as STIs or early stages of cancer. And if not treated, leads to infertility, ectopic pregnancies, miscarriages, premature births, and there's potential risk of cervical cancer. It has also been shown to increase the risk of getting HIV and other STIs due to the inflammation of the genital tract. And as you can see in these images captured via colposcope, on the left, before treatment, you could be able to see there were sandy patches and abnormal blood vessels in the cervix. And 9 months after treatment, you find that the lesions are mostly gone or have reduced significantly. So many clinicians, when observing, when they do, because we normally do VI villi we don't examine a colposcope, we may end up missing these lesions, and so end up treating this as STIs, which end up being recurrent. And this has been found prevalent in the Lake region around Homa Bay, Migori, and the coastal part of Kenya, Kwale, Kilifi. And so it's important for clinicians to be able to have index of suspicion for FGS as opposed to common STIs when females present with these symptoms. And you'd find that the treatment is very simple. At the facility level, all they require is praziquantel. Treatment with praziquantel ends up clearing these parasites and the patients are healed. For soil-transmitted helminths, albendazole or mebendazole are used in areas where we are having high rates of trichuris, like in the eastern part of the country and the coast part. There are new drug formulations combining albendazole and ivermectin to be able to target the trichuris species of STH. At community level, as I've said, because these are amenable to large preventive chemotherapy, we do mass drug administrations, a lot of health education, and safe water and sanitation. Moving on swiftly to trachoma. It's an infectious eye disease caused by bacterium called Chlamydia trachomatis, and it's a leading cause of infectious blindness globally. It has been eliminated in 25 countries, but remains a public health problem in about 32 countries. And so globally, over 100 million people are at risk in endemic areas. In Kenya, however, 5 million people live in areas at risk of these diseases. And the current active form of trachoma is found in Turkana, in Narok and Kajiado counties, where you can see the yellow and orange patches. So that is where current active infection is found. And this is usually between children less than 9 years old. The areas in green were previously endemic, but due to years of sustained mass drug administration, they have been able to clear, and so they no longer are a public health problem. However, we do have people in the community who have the blinding form, which is called the trachomatous trichiasis. And so these are found in parts of Turkana, like Laikipia, Baringo, Embu Kitui, Narok, and Marakwet. And this is how blindness comes about. When you get repeated infections of Chlamydia trachomatis, the eyelids thicken, especially the upper eyelid, and the scarring turns the eyelid inwards, which leads to trichiasis, which is now when the eyelashes begin structuring the eyeball, which results to corneal opacity, which is irreversible blindness. So the best part to catch this is before the repeated infections begin thickening the eyelid and the eyelashes begin turning inwards. So that is where we do mass drug administration to be able to clear the parasite from individuals who have been affected. And the transmission is through the direct contact from infected eye discharge, as well as the insects carrying the disease, such as flies. I know these are mostly pastoralist communities, so a lot of interaction with livestock, and this ends up and poor water sanitation and hygiene practices. So they do end up touching their eyes a lot and infected clothing, and this is high transmitted. So azithromycin, mass drug administration usually clear the bacteria, and these are done over multiple rounds, and then surveys are done to reassess the prevalence in the community. Once before a certain level, then that is stopped. And for young children around 6 months, there's a tetracycline eye ointment which is given to children. Those with trichiasis, surgery is done to be able to invert the eyelids to prevent the reversible blindness. I'll move to another NTD called lymphatic filariasis, which is a vector-borne parasitic disease. So 3 species of filaria. The one we commonly see is Bushraria bancrofti, we have Brugia malai and Timori. And this is mostly common in the coastal part of Kenya. Hence why you see the common names in Swahili: Mguu mzito, matende, mshipa wa kushuka, tende, pumbu, toma, etc. And this is transmitted via mosquitoes. So mosquitoes bite an infected individual and transfer the larvae from humans during blood meals. The adult worm lives in the lymphatic system of an infected individual for 6 to 8 years. And now the microfilaria usually circulate in the blood, usually at night. And so there are multiple countries currently endemic for lymphatic filariasis, as you can see, either in the deep blue, the ones in the light blue, the ones that are not effectively achieving mass drug administration. And as you can see on the right, the map in Kenya shows that this disease is mostly confined to the coastal part of Kenya, 6 counties of Tana River, Taita Taveta, Lamu, Kilifi, Kwale, and Mombasa County. And so lymphatic filariasis has acute manifestations. And usually after infection, because the adult worms stay in the lymphatic system for a while, they end up blocking the lymphatic system. And so what usually happens is that there tends to be local swelling, warmth of the limbs, redness, and extreme pain in the affected areas. And there are non-specific symptoms such as fever, chills, and headache. And in some people where they get infection and they get lymphedema, you do find the skin spill, which is normally a sign of a recent acute attack where the lymphatic system is blocked, or when because of the itching and scratching, they end up introducing bacteria or fungi, and they get acute attacks of lymphatic filariasis. For chronic manifestations, this usually happens many years post-infection, and the most common recognizable ones are lymphoedema. As you can see on the right, a very swollen right limb. The picture in the middle shows a swollen inguinal region, and on the right you can see a swollen breast. And so this is because of the blockage of the lymphatic drainage, and so ends up with accumulation of fluid and ends up damaging the lymphatic vessels in these respective organs, leading to chronic manifestations of this disease. Unfortunately, reversal of the lymphedema is not currently possible, but for the hydrocele, we are able to conduct some surgery. And so how is diagnosis usually conducted? The gold standard is microscopy, where you will need to take a peripheral blood film and stain GEMSA, and you'll be able to see the microfilaria. There are other methods of improving the sensitivity of the tests, which are, for example, the NOS technique and the membrane filtrations, which are specialized lab techniques to concentrate and be able to see the microfilaria. To note is that it has been shown that these microfilaria have a nocturnal periodicity, in that if you want to see them, night samples are usually done at night between 10 p.m. and 2 a.m. So even during surveys at the National Ministry of Health, the vector-borne and NTD unit, when they usually conduct them, we do find that they do rapid tests, which is now the antigen detection, which are used during surveys. These are not commercially available tests, but donated to the country. And so they go test school-age children who are supposed to be free of the disease after a couple of rounds of mass drug administration. If you get a positive test, then those individuals are traced back to their homesteads, and a night blood sample is taken between 10 p.m. and 2 a.m. to be able to demonstrate microfilaria. And so of late, Kenya has made significant progress towards this, where to the point of we'll not be needing the mass drug administrations in mass for entire sub-counties. Only particular clusters of infection are currently being found through these surveys. Also, there's a lot of vector control going on, integration in the National Malaria Program, where you find that mosquitoes are collected and they are tested for the presence of the parasite. And areas you're finding the parasite, then they're able to know that there's ongoing transmission, and corrective measures can be done through the mass drug administration in those particular areas. However, there are also antibody detection kits that are commercially available that test antimalarial IgG1 and IgG4 antibodies. These can be bought and used in facilities for patients who are suspected to be positive for this particular disease. So as I've said, prevention and treatment are almost the same for these two diseases. The prevention is through the preventive chemotherapy mass drug administrations, and there are two regimens currently available to treat this disease. The first one is a combination of diethylcarbamazine and albendazole given at the same time. And the second one is a combination of ivermectin, diethylcarbamazine, and albendazole administered at the same time. And so the rationale of doing these mass campaigns is to reduce the density of the microfilaria in the bloodstream, so that when mosquitoes do end up biting people and taking a blood meal and biting another individual, they do not end up spreading the larva. So with the diethylcarbamazine, in areas that were above a certain threshold, they required administration for at least 5 consecutive years to be able to reduce the prevalence below a certain period. For the triple therapy, what we call the triple therapy, the ivermectin, the duration of treatment is shorter, about 2 years. And if required, you can do supplemental rounds depending on what is found from surveys. And so this is how you treat lymphatic filariasis. So even in any individual who presents with this, the regimen would be diflucabamazine and albendazole. So the chronic manifestations, for example, hydrocele management. So hydrocelectomies are done for these patients, and currently the technique advised is a complete excision of the tuner. As you can see on the right, this is a case report of junior medical camp in collaboration with the University of Nairobi and the Kingdom National Hospital done in 2023, where the Department of Urology and Surgery was able to support the counties, of course, to be able to refine the technique of hydrocelectomy to prevent recurrences. And this involves excision of the entire tunica and the suture of the lymphatic system to prevent continued accumulation of fluid in the hydrocele. And in some of those patients were draining up to 5-6 liters of fluid that are accumulated in their inguinal parts. Another common manifestation is what is called adenolymphangitis. This usually occurs in patients who have lymphedema and swollen limbs. So because of the blockage of the lymphatic system, they are prone to acute attacks. And so usually you need to have pain relief, topical antifungals if they have open wounds, and antibiotics for secondary treatment where indicated. And so for many of these patients, they're being taught home-based care, where they wash their limbs in soap and water, keeping them dry, raising the limb to accelerate lymphatic drainage, foot exercises, improve their footwear to prevent injury, and wound care, immediate wound care to prevent abrasions. Because unfortunately, this is a non-reversible condition. They'll have to live with it for the rest of their lives. And so just making sure that they do not get secondary infections. And so a lot of programs are now aiming to do home-based care. So all patients who present to a health facility with acute attacks, after treatment, they are taught about this home-based care so they can be able to take care of themselves better. So I'll move to another NTD called leishmaniasis. So this is transmitted by the bite of an infected phlebotomine sandfly. It's associated with malnutrition, population displacement, where people from a non-endemic area end up moving to an area that is currently endemic, poor housing structures allowing the sandflies to get into the houses, weakened immune systems, financial resources are basically talking about people of a poor socioeconomic background. But to note is only a small fraction of those infected by these parasites end up developing the disease. And so there are two main forms of leishmaniasis. And I'll begin with visceral leishmaniasis, which after malaria, the second deadliest parasitic disease globally, has a mortality rate of 95% in 2 years if left untreated. And Kenya is among the 10 countries reporting more than 90% of the cases globally. That is together with South Sudan, Ethiopia, South Sudan, Ethiopia, and Brazil. And in the last 3 years, we've had about 7,000 cases. Previously, the country was reporting about 1,500 cases of visceral leishmaniasis. So 2025 presented the year of the largest outbreak ever recorded in the history. Where more than 3,700 cases were diagnosed. And we are finding that this disease is found in 13 endemic counties currently. So that is the counties of Mandera, we have Garissa, we have Isiolo, Marsabit, Turkana, West Pokot, Baringo. Samburu is the latest county that has been detected with diseases. You have Kitui, you have Tharaka Nithi, you have Kajiado County. And so it's important to know how these patients present, because normally a bit of confusion. So one is, the reason I was mentioning those 13 counties is that usually patients are either residents of those areas, those counties, or have a recent history of travel to those endemic counties. And usually they have fever for more than 2 weeks. So the case definition tends to be have fever for more than 2 weeks. with the presence of splenomegaly or extreme weight loss, and malaria has to be ruled out, or no clinical response to effective antimalarial treatment, because it does present as an acute, as a febrile illness, as a chronic febrile illness, and so most of the time people are treated for malaria. So it's important to rule malaria out before you can diagnose visceral leishmaniasis. Other common symptoms are anemia, and people may present with a cough. Nose bleeding has been shown to be there. Some have hepatosplenomegaly, where both the liver and the spleen are swollen, and out of body weakness. So visceral leishmaniasis is normally considered to be a chronic disease with an incubation period of about 2 to 6 months. However, there are a few cases, depending on a person's immunity, where the disease may present acutely. So the standard case definition would be splenomegaly, and fever for more than 2 weeks and splenomegaly with a negative malaria test. And so I thought it's important just to show this algorithm for VL, just to acquaint ourselves with how it usually is. So if you have fever for more than 2 weeks with splenomegaly and without malaria, the gold standard is a parasitological test. This would either be a bone marrow aspirate or a splenic aspirate to demonstrate the presence of mastigotes in the peripheral blood film smear. However, in most facilities, we do end up doing a rapid diagnostic test. The one currently available in the country has sensitivity about 7%. Therefore, you expect about 30% of cases who present with the clinical signs and symptoms, the classic signs and symptoms, may end up not being diagnosed. And so if that is negative, you do a direct agglutination test, which then now you look at the antibody titers. And so the titers are above 1 to 200, well, 1 to 3,200, then you initial treatment. If these patients have between 400 and 1,600 titers, normally you do a retest or you do a parasitological test. And if they're negative, then you do look for other clinical diagnosis. This has been confused with, of course, CML, because CML presents also with splenomegaly and other conditions that do present that, like brucellosis, you have the hyperactive severe malaria, etc. So just as a reiteration is that splenic aspirate, the sensitivity of getting a mastigote in a patient who has classical signs and symptoms is about 95%. But of course, you have the risk of bleeding. And bone marrow aspirate is a bit safer, although very painful. Sensitivity, you're getting positive mastigotes about 70%. And you can see the mastigotes in the PBF shown image below. On the bottom right extremely is that there's a direct agglutination test, which now lab officers are taught how to prepare. So the good thing about a DAT is that it can be done in a peripheral facility. With the right reagents, you can even use a dried blood spot or serum. And now that is titled on these plates, and they're usually left overnight to read for agglutination to happen. So reading is usually after about 12 hours. Other methods of diagnosis include PCR on blood or bone marrow samples. So with regards to the treatment, the first line combination of visceral leishmaniasis is a combination of sodium stibogluconate and paromomycin for 17 days. And the dosage is about 20 milligrams per kg for SSG, IM or IV. And for paromomycin is given IM for 17 days. So these are usually very painful injections for the patients. They need to be managed as inpatients because of the risk of toxicity. These drugs have been shown to have cardiac toxicity, hepatotoxicity, and so and also cause kidney damage. And so it's important for patients in these areas to be monitored clinically, as well as the laboratory tests to ensure that they safely go through the regimen. Where paromomycin is not available or when it's contraindicated, you do have monotherapy with sodium stibogluconate for 30 days. So 30 days of continuous injections. And paromomycin has been associated with a lot of vomiting for patients. And so some people pre-medicate their patients to alleviate the vomiting, but this tends to be the first line therapy. Second line therapy is the liposomal amphotericin B. And in brackets here, I put ambisome for a particular reason. So this ambisome is the original molecule produced by Gilead. And so during clinical trials when they were treating patients, it was shown to have a better safety profile than the usual liposomal amphotericin B and has a better bioavailability. And this needs to be reconstituted in 5% dextrose and given as a slow infusion over 30 to 60 minutes. And you can see the recommended dose is 3 to 5 milligrams kg per body weight, given as an infusion for 6 to 10 days, with the maximum dose of up to 30 milligrams per kg. So this liposomal amphotericin B is also the first line for pregnant women. If a patient has been treated with the first line combination therapy and relapses, then they are put on liposomal amphotericin B. Patients who are severely ill who will not be able to tolerate sodium gluconate and paromomycin are given liposomal amphotericin B. Children less than 2 years and adults over 45 years are considered to be high risk, and so given this, patients who are leishmaniasis and HIV co-infected are also given this regimen. And so it's important to use the original molecule for treatment of this liposomal amphotericin B. If you're to use any other formulation, it's important to consult a physician because you may need to lower the dose significantly if not available. So these drugs are available through the Ministry of Health, and so they can be distributed to areas where they're required. We do know that there are certain parts of the country that have requested for medicine from the ministry and they're able to be given them. So I'll move to the last entity for today, which is cutaneous leishmaniasis, which is the more common form of leishmaniasis and causes skin lesions, ulcers on exposed body parts, and causes a lot of scarring, disability, and stigma. Over 1 million cases are reported globally, with many of them being in South America. You can see northern parts of the African continent, as well as Southeast Asia. And so it has various clinical manifestations. The first one being a localized, which begins a small papule that enlarges, forming nodules and plaques, and crusts eventually in the middle. And so this one can be single or multiple, and usually occurs in the face or in exposed body parts like the arms. But on the face occurs in more than 90%, and usually has a clinical incubation period from a few weeks to several months. And so this is what we commonly see. And for patients from Kajiado, is currently experiencing a lot of cutaneous leishmaniasis. This is also seen in Nakuru area around Gilgil. We have parts of Laikipia, Nyandarua, Elgeyo Marakwet. There have also been reports of cutaneous leishmaniasis. A team from Cambry and called ISIPE, they do some surveillance for the vectors, because the sunfly that causes cutaneous leishmaniasis is not exactly the same sunfly that causes visceral leishmaniasis. And so these have been found in other parts of the country, although no clinical diseases have been reported. Then we do have the diffuse type, which is quite rare. But this one usually begins as a few nodular lesions and then gradually spreads. And normally these lesions appear on multiple areas. So you may find that it disseminates through the bloodstream, and you may find lesions cropping up in various parts of the body. And so this is a chronic disease, and it's quite difficult to treat. The third type is called recidivans, which is a chronic lapsing form. Not very common, but even if it heals, it tends to relapse and may be resistant to standard regimens, which I will take you through. So this one may require a lot of systemic treatment as opposed to the first two, which usually respond to local therapies. And so how we diagnose these ones are through a slit skin smear. So clinicians need to suspect somebody from these endemic areas, conduct a slit skin smear, and then be able to do peripheral blood film. And then you can also do FNAs, you can also do PCRs. But confirmation is highly encouraged. And where you're not sure, you can be able to refer. You can do aspiration or scraping or tissue biopsy to be able to look for the mastigotes. And you can see when you do a slit skin smear and you stain GMSA, which most peripheral labs can be able to do, you can be able to tell whether this is a case of cutaneous leishmaniasis or not. And its treatment usually depends on the size of the lesions the number of the lesions, the location of the body, and whether it's one of the three types of the leishmaniasis I've brought up before. And so the topical ones, the one with the less lesions usually responds to topical therapy. So where you can do cryotherapy, or you can do injection of the sodium sibogluconate for about 4 to 6 weeks. Thermotherapy has also been shown to work. We can do interlesional antimonials, which is sodium sibogluconate for about 3 to 4 weeks. And these patients need to be followed up for up to 60 days, up to 180 days, sorry, just to make sure there is no recurrence. For the one with multiple lesions or is more spread or is disseminated, these ones require systemic treatment. So they feel like the normal patients with visceral leishmaniasis, only that now the sodium sibogluconate IV is given for about 28 days. And there's a new drug called metformin, which is going to be introduced soon enough, which is the first oral therapy for leishmaniasis, although it is teratogenic, and so is not to be used for women of childbearing age if they are or pregnant women, or if they're intending to have children. If they need to, then these are women that will need to be put on a family planning method of their choice. Otherwise, this treatment cannot be used for those women. The challenge we have with leishmaniasis is that the medications are quite toxic and very few, but there are individuals working to be able to bring new and safer therapies for leishmaniasis. And so I'll just briefly touch about snake bite as we complete. So snake bite, we do know. So last year, there was a symposium that was held for snake bites to educate healthcare workers. And if you Google East Africa Snake Bite Symposium, you'll be able to see a lot of online resources and videos showing about the medical importance of snakes in Kenya. Kenya reports about 15,000 cases of snake bites annually. And of all the species of snakes in Kenya, only nine are venomous. And we know parts of the country that mostly report the cases like Wajir, Turkana, Kilifi, Kitui, Baringo. And so just to be able to educate yourself further in the interest of time, I just put this up as to show online resources that you can be able to get with regards to snakebite in Kenya. So this was a webinar series where resulted in a formation of a WhatsApp group chat where clinicians do share practices or question about the types of snakes. Is antivenom indicated or not? How to pre-medicate? How to monitor after administration of antivenom, when not to administer. And so it's a good learning forum. And we hope to replicate this through a webinar like this one we're having now, where we can go into more details about specific diseases and others coming up. So I would like to thank the National Public Health Institute. So if you want to contact Mr. Kyoko, who works with the vector-borne NTD unit, I myself work with Health Africa currently, and Dr. Errol Sigay from KMTC. And this year, we have the World NTD Day, scheduled for January 30th, which is next week on Friday. The national celebration will be held in Kajiado County, which is a county that is endemic for a couple of NTDs. We have soil-transmitted helminths, we have trachoma, we have visceral leishmaniasis, we have cutaneous leishmaniasis, we have snake bites. And so it will just be a forum to raise awareness about this on a national platform. And you're all invited for that. Thank you all. And back to the moderator.
Thank you for taking us through that presentation, Dr. Kibati. And now we'll move over to our Q&A. And to our participants, you can post any questions you might have on the Q&A section, and we'll be able to pick it up. So for the first question, there's one question that has been posted. The question is, spine involvements by schistosomiasis, and I think, Doc, you can take a look at this. I'm having a difficult time pronouncing those conditions. And maybe you can respond. Are you
Thank
able
you.
to say?
Yes, so I
Yes,
have
yes.
had, yes, so I have heard of a case of position tuberculosis function in the bloodstream can be able to lodge in any particular area. So if it does not cause granulomas and chronic inflammation, then conventional treatment can be able to clear schistosomiasis. However, if now it results to a chronic form, just in spine involvement, then of course we need more advanced medical care, requiring imaging to be able to see whether surgical intervention may be required or not. But in the early stages, it usually is not required, as well as the conventional medication for leishmaniasis hereditary currently is quite effective if caught early. I know we see a lot of hereditary disease in Turkana and then West Pokot in that particular area. And so this can be able to be well treated with conventional therapies that currently exist.
All right, thank you. As we're waiting for more questions, I can see the appreciations coming through on our chat. Participants really enjoyed your presentations, and they're thanking you for learning, sharing your knowledge on this particular topic. We have the next question from Wanga. The question is, the cases we have seen seems to be prevalent in hot or warm climatic areas. I think this is just a comment, but if you'd like to add on that, Daktari, you can proceed.
Thank you. So for the, yes, we do see a lot of NTDs in hot climatic areas. So these are the ones that result in opposition of many of these conditions where it's ripe for things like snake bites and where the vectors primarily are able to reside. So these are areas that need to be targeted. Um, with regards to deworming for albendazole, so the national program does the mass deworming depending on the prevalence. If an area is above 20% prevalence, they may do once every year, between 10 and 20% prevalence in the entire community once every 2 years. However, on an individual basis, there's usually the common rule of you can deworm once every 3 months with a single start dose of albendazole for more than 2 years, or mebendazole, which can be used in children less than 1 year.
Right.
For hookworm infestation, if I can move to the next question.
Yeah. Yes. For how long should one treat hookworm infestation?
Usually, if it's a mild infestation, a single dose should be able to treat it effectively, unless one has a very heavy infection, which in the case we may need maybe a repeated dose. But usually, one dose is usually sufficient to treat hookworm.
All right. And then to our participants, kindly note that post your questions on our Q&A and just keep the chat for your comments. The next question is from Millicent Ouma. She's asking, kindly shed more light on how to completely cure FGS, since WHO says that PZQ only targets the adult worms and not the juvenile ones.
Millicent is completely spot on that. So currently, the only guidance we have is that single dose of treatment per body weight for women to be able to clear the parasite. And so we don't have clear guidelines about when to repeat, but clinicians are discretion to be able to repeat the dose because it is not toxic or there's no harm in a repeat dose after, let's say, for example, a month. But there are no clear guidelines at the moment. I think once we have those, the Ministry of Health will be able to circulate them. I think Millicent was part of the team that was doing FGS in Homa Bay and Kwale, looking at the integration into the healthcare system. And so, yes, clinical guidelines are currently being rolled upon at the national level, which will be distributed to healthcare workers once available.
All right, thank you. The next question is from Kenneth Maura, asking, is there emerging evidence of drug resistance in NTDs? If yes, what are the treatment protocols?
Thank you for that very good question. Currently, we have not seen issues about drug resistance for NTDs. I'm speaking here about, for example, like trachoma, speaking about azithromycin, which we know is commonly used quite badly, I may say, by common healthcare workers. I mean, sorry, by people once they have a cold in the etc. But so far, we've not been seeing any issues. The issue we may have is about soil transmitted helminths, especially trichuris, which conventional treatment with albendazole and mebendazole is not completely clearing the parasite. So combination therapies with ivermectin have been developed to be able to assist with this.
All right. Over to the next question from Collins Uto. Are there any targeted interventions being undertaken for non-human reservoirs for the NTDs? And then the second part is, what is the availability of POC CCA antigen test in our public health facilities? And are there any coordinating labs within the counties having less than 10% prevalence?
Thank you. So currently, for the non-human reservoirs, we've not been able to conduct any interventions, which will be molluscicides to be able to target the intermediate host, for example, like the snails. So those have probably not been done because the environmental implications that may be there. So until they are fully understood, those are yet to be implemented. However, it's a thing that is being thought about because there's sampling going on in various areas. You may find one snail may shed thousands of cercaria and be responsible for a lot of infection. With regards to the availability of OxyCA, that is currently not publicly available in public health facilities. Mostly they're being used in research settings.
Apologies, I think I was on mute.
Okay.
So I was actually reading out the question from the anonymous attendee. Is kindly share some knowledge on the management of snake bites and the administration of antivenoms in age groups. Snake bites are normally in our area, and we actually lost a pregnant mother who was at term due to snake bites.
Yeah, so snake bites are common in quite a number of areas, and the treatment depends on which type of snake bite. So of course we have the neurotoxic snakes, we have the cytotoxic snakes like the puff adder, the neurotoxic and the mambas, and then you have the ones that cause uh hematotoxic that cause bleeding tendencies. So what we have in the country currently is a combination of multiple venoms in one, which can be administered to patients when they have snake bites. And just to join this with another question is about the patients who react. Yes, there are components in the antivenom that may make a person react because the process of manufacturing an antivenom means milking the venom from the snakes themselves. Then they immunize animals such as horses, and then they're able to extract the antibodies from that. And so those cross antibodies at times cause reactions with human beings. So usually you're advised to provide a prophylactic dose of antihistamine to be able to reduce the effects of the antivenom because in the interest of time, you may not have time to do an allergen test to a snake bite. If a patient is having a venomous snake bite, what they require is antivenom as there's no other therapy. And so Usually, you're advised to follow the manufacturer's leaflet about the administration, but mostly it should be given as a slow IV infusion, and the number of vials can be repeated until you neutralize the snake venom. One thing that has been found, and why I was sharing the page about the antivenom, the snake bite symposium that was held last year, is because you're finding even within a country, different venoms harvested from the same type of snake have different venom quantities, when I say, or the active component of the venom. And so that is why it's important, like for example, for antivenoms in Kenya, to use antivenoms from snakes that were actually made in Kenya, which is what the Ministry of Health, through the Institute of Climate Research, is doing, being able to actually harvest snakes locally. There's also a snake farm in Watamu that is doing the same. And so it is quite complex in terms of the availability of the actual antivenom to be able to neutralize the antivenom. And if you look online, we do have some publications of people who actually bought commercially available antivenoms that were imported parallel, and their effect on neutralizing antibodies in the country may not be as good. So it's important to follow the Ministry of Health regulations in terms of which snakebite antivenom to stock, which is normally kept by KEMSA.
Once again, this question is from Miri Kimani, asking amphotericin B is actually nephrotoxic. She's asking, what is your experience, especially in patients with impaired renal function?
Thank you for that question. So these patients are usually the dose would be titrated before the dose of amphotericin B would be titrated before administration for these patients, because we do know that the combination of sodium gluconate and paromycin may also cause further kidney damage. So the patients are usually well prehydrated, dose titrated appropriately, and monitored closely, and they do usually recover.
All right. Another question from anonymous attendee is, how often should adults take prophylactically for STH?
I don't know if my colleague Esther or Dr. Sigea online, they could also be able to provide a few answers to this.
Esther, you can unmute and respond to this. I can also see Dr. Sigei on the call as well.
Kindly repeat the question. I'm having internet issues. Kindly, if they can hear you, Dr. Kibati.
Yes, apologies for that. The question is, how often should adults take prophylactically for STH? Were you able to hear me?
If they're not in a position to take the question, I could respond.
Okay.
Yeah, so I wouldn't say take prophylactically, but deworming every 3 to 6 months would be advisable for all adults. Usually, by our lifestyle of liking things like salad, etc., it is possible to get or fruits and vegetables that are not washed appropriately. It is possible to get infection with these conditions. So 3 to 6 months would be okay to deworm.
All right. Thank you. Jacqueline Juma is asking, what about Tunga penetrans is common in village setup, even in households practicing wash?
Yes, so Tunga penetrans, commonly known as jiggers, is also a neglected tropical disease, and you do find it in. It tends to occur in clusters of households, and so usually these ones require a lot of behavioral changes, not wearing barefoot, being able to improve the floors of these houses, because you do find many of them, the floors are mud houses, and so they're able to pick up the infection from the soil. And so improvement of the floors, wearing shoes and hygiene normally is a preventive measure. However, once infected, of course, they need to be plucked out, they need to be washed, the feet need to be washed and cleaned appropriately. And the application of some oil, oil to be able to alleviate the symptoms.
Thank you. One question on albendazole. Albendazole. Someone is asking, which duration can it be given? Is it start or once per day for a couple of days or 2 times a day, and for how long?
That dose usually is appropriate for albendazole. So once a day. The only time albendazole is indicated for a long treatment duration is the treatment of neuropsychosis. But otherwise, for common soil transmitted helminths, one start dose is sufficient.
Thank you. Questions from the chat, and then I'll still like to remind our participants, or rather our attendees for today, kindly post your questions on our Q&A. It will be easier for us to retrieve them so that we can be able to respond to you. But one question from the chat box is it okay to deworm children under 1 year?
I would say it's not, unless medically indicated, there will be no need to deworm a child under 1 year. Once they're over 1 year, then you can be able to safely deworm them using albendazole. And once over 2 years, you can use albendazole. This is because the way the tab comes, the tablet may not be maybe too high a dose. So unless medically indicated, I would not advise deworming children under 1 year old.
Okay, another question from the chat from Joseph Macau is, how do snake bites affect communities in Kenya? What actions can RMOH and AMREF taking, and why should national resources or donor funding be directed to reduce the burden?
Thank you for that. Looking at snake bites and the communities they affect more often in peripheral areas with limited access. So community awareness is one action that the Ministry of Health is taking up through the National Public Health Institute and the Institute of Climate Research to be able to educate community health promoters to go and educate communities about snakes. One thing is that they are important in the ecosystem, but often when we encroach into their ecosystem is when now we do find cases of snake bites. And so the main thing would be to learn about preventive measures, how to avoid being bitten, where you're at risk, and how to mitigate against those risks. If bitten, some things need to be undertaken. Like one, if you have any tight clothing, they need to be released. So at times we see people using tourniquets. So to tie the limb to prevent the venom from spreading, that is a very harmful practice. So they should not do that. Secondly, going to traditional healers where they use a black stone to be able to suck out the venom, that does not work. So in the cases where this has been mentioned to have worked, it is mostly because majority of snake bites are actually dry bites. And so they may bite you but not inject venom. And so if a traditional healer puts a stone and then you do not end up having inflammation, then you may think that the stone actually helped you. But this may not be the case, because what it was is that it was either a dry bite, or if it's a venomous snake, it did not inject any venom. You need to immobilize the limb. That limb needs to be kept as still as possible. So treat that limb as a fractured leg. So if can possible, you can splint it. The way when somebody has broken a leg or an arm, you're able to put, for example, like sticks and just immobilize it. And so that patient should be taken as quickly as possible to the nearest health facility for assessment. So that is what should occur. And in terms of resources, so it depends on the priority. So national government and county governments need to be able to prioritize this as much as they prioritize other health conditions. And so it's not the duty of any one individual, but it's a collective effort that needs to be taken to be able to mitigate against all these NTDs.
Right. Thank you. Another one from Millicent Ouma. She's saying an addition on schistosomiasis prevention. Social behavior change communication will also be important. She's saying CHPs as change agents during community dialogue, sensitizing community opinion leaders, etc. Also adding on male genital schistosomiasis, have the same impacts just like females. If you'd like to comment on that.
Yes, I completely agree that the social behavior change communication is very important, not only for schistosomiasis, but for all other neglected tropical diseases. Because you do find the hardest part of any disease control program is changing the human behavior towards that particular issue. Because you may find that particular human behaviors predispose you to getting a condition, and if not addressed adequately, then patterns of infection will continue. So no matter how many times you may deworm residents of the Lake region, for example, those who are fishing Lake Victoria, they will still have to go there for a living and get exposed to water and end up getting schistosomiasis. It ends up becoming a repeated cycle of infection treatment. So it's for them to know that, for example, you should not defecate in the lake because now one person who's carrying the parasite, once it's put into the water, the Saccharia develop, and then it continues a continued pattern of infection. And so it's important just to be able to teach community health promoters to continuously educate people in the community.
All right. And another question here is, what is the psychological rationale of not deworming children? Because an article indicates that the traditional practice of not deworming was due to commercial reasons to the companies that actually make these drugs.
That's a very interesting question and opinion, because yes, the thing about deworming is that you need to be able to understand who's at risk. And so deworming practices are more, regular deworming needs to be dependent on the level of risk. If you are at high risk, then you'd require more routine deworming as compared to someone who exemplifies good water sanitation and hygiene practices. That person will be less affected to be able to get the disease and hence does not need deworming. So that's what I would say about that.
Okay, thank you. For the next one, I'd like to combine two questions. What is the best management of tungiasis, and also is potassium permanganate recommended for treating the same?
So one thing about jiggers is that it has no effective curative treatment at the moment. The best thing would be to target the the jiggers themselves as vector control to be able to ensure that those jiggers are not present there. So that vector control would be the best thing to do. However, basic treatments like removing them with a needle or application of potassium permanganate or traditional hydroxide. Some people also use ash to repel them from the households. You need to be able to, for those who live in mud floors, they need to be able to regularly wet the floors just to reduce breeding areas. Coconut oil or aloe vera has been said to be effective, but in all what we currently know as the body of evidence, we don't have that one effective curative treatment for jiggers. So the best thing would be preventing the jiggers in the first place, by ensuring that they are not present in your household and homestead.
Okay, thank you. The next question is from Jacqueline. How can one clinically differentiate from cervical schistosomiasis from other cervical infections like cervical cancer? And what is the treatment?
So for the differentiation between female genital schistosomiasis and the early stages of cervical cancer, you'll be able to look at when you examine the cervix for women, you'd be able to see it'll be like yellow sandy patches. And so you have to be taught by a clinician to be able to differentiate between these two conditions. What appears as cervicitis from schistosomiasis and what is from the early invasive cancer. So usually diagnosis is done by a colposcope. So you can be able to visualize the cervix. And then once you're able to visualize the cervix and see that you have those yellow grains, sandy patches, then you can be able to know that's female genital schistoma. Also, the area where the person is from plays a big role. In an area where there's no schistosomiasis endemic in that particular area, then the cervicitis will probably be due to a different causative agent as compared to that of a female genital schistoma. Thank you.
Okay, thank you. Another question from Ezra. He's asking prevention measures of NTDs. Prevention centers on water sanitation hygiene alongside preventive chemotherapy, vector control, and improved animal health, using integrated strategies to block transmission through clean water, hygiene practices, and drug administration.
I agree. So one thing that is common with the preventive chemotherapy entities, that is schistosomiasis, such as Mitchell-Helminth's, trachoma, is that they are amenable to better water sanitation and hygiene practices. Where these practices are done pretty well, you do find a very low prevalence of these diseases as compared to areas that are not. And of course, the behavior change cannot be overemphasized for individuals.
Okay. This one is a comment on jiggers saying ICP has been using benzoate, which has had positive feedback so far, although it is not yet approved. Can you make any comments on that?
Yes. So currently, there are many trials going on, if I may say, to see which is the most effective. And that is why I'll say the body of evidence currently does not tell us which one is the most effective. So what they are doing is to try to show if that particular regimen would be important, and if indeed it is effective to use for jiggers, that is. Yeah, so the body of evidence is still being built, and there are many other things being tried. I know of neem and coconut also being tried to see if that can be able to alleviate the symptoms, but we don't have any definitive treatment for that at the moment.
All right. I can see a participant with their hand up. Sylvia, if you would like to ask the question online, kindly keep your hand up. If not, you can lower your hand, but we'll give you the opportunity in just a few. Another question, Daktari, is this is a great informative presentation, and they're asking, is the female genital schistosomiasis transmissible through sexual contact, and can the infected person spread it through public swimming pool, through like swimming in a public swimming pool?
Thank you for that question. So, female genital schistosomiasis is not a sexually transmitted disease. The way somebody gets infected by the way someone gets female genital schisto is by, for example, walking or exposure to water, freshwater bodies in which there are snails that are actively shedding what we call the cercaria. So even if an individual has female genital schisto, they are not a carrier per se. It's not a person-to-person transmission. It requires an intermediate host, which is a snail, which will be splitting the cercaria to infect somebody else. So the answer to that is no to both.
Thank you, Sylvia. If you still like to ask your question, we will allow you to speak and ask the presenter your question. So kindly go ahead. Sylvia Ntiga, you can unmute and ask. All right. We can move on to the next question from our Q&A. Immaculate is asking, while treating tinea infection, should deworming be included in the management?
It's not indicated. Unless medically indicated, deworming will not be necessary when treating that.
All right.
But I can let maybe Sige or Esther add to that if they are back online.
Esther, if you're with us, you can kindly unmute. Dr. Sige as well.
I can see them typing in the chat to answer some of the questions. And, yes, but that's it. No, it's not. Unless medically indicated, you do not have to.
Okay. We have a question from Victor Bet. I don't know whether you can see it from your end.
Yes, I can see the question.
All right.
Yes. So because of the periodicity, we do have so how we diagnose acute lymphangitis, the acute attacks, would be a patient who lives in a lymphatic filariasis endemic area and clinically diagnosed as having lymphedema. So those patients with clinically defined lymphedema, when they do have the acute attacks of pain, then you'll be able to attribute this to acute lymphangitis and be able to treat. It's also good to know that even if the cause is not due to lymphatic filariasis, the blockage of the lymphatic vessels and the subsequent co-infections can result in these acute attacks if they are acute bacterial infections or fungal infections. And so treatment would generally be the same. Because of the periodicity, the nocturnal periodicity of the antigen, usually we only take the blood films at night, and those we usually just prefer to do them during surveys. However, there are new tests coming out, which will be commercially available, which we're looking at IgG1 and IgG4 antigens against antifilarial antigens. And so these, in a patient with lymphedema, you can be able to test them. And if they do have the IgG antibodies, then you can be able to confirm that it's actually an LF patient.
Okay, thank you. in the interest of time, I think we'll take two more questions before we conclude. The next question is for STHs, specifically hookworms. Zentel, in brackets ABZ drug insert, recommends 400 mg for 2-year-olds and above. OD for 3 days, followed by repeated dosing after 21 days to eradicate residual parasite load. In brackets, previously lung escond and eggs that are developed into larvae after the initial therapy. They're asking you to kindly clarify on this information.
So thank you for that. So Zental here refers to a specific brand of albendazole. And so that is why I was saying that usually a start dose is usually enough to be able to treat the infection. However, you can repeat dosage after a month or after 3 months, unless somebody has a very high load, which is now symptomatic. For example, which is not symptomatic, then usually you do not need to repeat the dose that frequently. However, because the bioavailability of the drug, it will not be harmful to treat for those 3 days to the individual.
All right. I can see we have one question remaining. Is there any role for antiprotozoa plus antihelminth as a routine for deworming preference?
There, whichever deworming preference you use to take, because mostly what you have are the soil transmitted helminths, mebendazole or albendazole are usually sufficient. If you live in an area endemic for schistosomiasis, then praziquantel could also suffice in terms of deworming. But usually now, unless you're clinically indicated, you may not need to take these deworming medicines. However, the National Ministry of Health usually determines through community surveys once prevalences are above a certain level, then they can be able to provide mass drug administration targeting all members in the community.
Okay. Victor Bet is back once again. I think with the last question we do have for this session. How does treatment of doxycycline disrupt the transmission of lymphatic filariasis, and why is it effective?
So lymphatic filariasis. Okay. So currently in Kenya, according to our regimen, we usually use the carbamazine and albendazole combination, or with ivermectin for treatment of lymphatic filariasis. Doxycycline has been indicated for use, but not at mass scale. That will be for individual treatment, but that would also depend on the type of lateral antigen that you currently have. Is it Ushirenia, Briomycin, or the other one? But generally, what we use in Kenya is carbamazine plus albendazole. Thank you.
Thank you so much. And this will bring that brings a close to our question and answer section. And just to note to our participants, I will be posting, or rather, the link to the WHO booklet for clinicians has been posted, and I will be sharing it with you momentarily. For now, I would like to ask our panelists for today, that is Dr. Kibati and Esther, if they have any closing remarks for this session, as I post the link to that particular booklet.
I'll go first, and then my colleagues can follow. Mine is to thank all those who've been able to join from various parts of the country to be able to learn about neglected tropical diseases. This requires concerted efforts for creation of innovative ways to be able to innovate behavior change, communication, repeated advocacy at all levels of government and international, so that we can be able to eliminate these diseases as a public health problem from the country. Thank you, and over to Dr. Sigay and Esther.
Maybe I can go second. Thank you so much, Dr. Kibati, for the good presentation. And ideally, I would also say is that just to allude to what you have said, it engages concerted efforts for us to eliminate NTDs, because we all know that they are neglected. And we would love to invite you all to the World NTD Day, that is this year 2026 commemoration, that will be happening in Kajiado County. We hope to learn more and engage more. Thank you.
Thank you, Dr. Sige. If you're still on call, you could maybe just give us some final remarks. And as we wait, I would just like to point out that links have been posted on the chat box. You can find the links to the Kenya NTD Master Plan 2023 to 2027. It has been posted there. You can access it. We also have the WHO booklet for clinicians that also has been posted. So you can get this and get more information on NTDs. So with this, I would like to appreciate the teams from Ministry of Health, Dr. Kibati from AMREF Health Africa, together with your colleagues, for the wonderful work that you're doing. Also like to appreciate the National Public Health Institute for organizing this particular session. And as mentioned, there will be that upcoming World NTD Day. I do hope that we can be able to provide invites for our participants. Whether we can do it online, we would appreciate if we could have you guys once again on our platform, so that we can continue spreading the message of eliminating NTDs in our country. So once again, thank you, Sana, Dr. Kibati. Thank you, Esther, and the KMTC team. Thank you, Dr. Sige, for also helping organize this particular session, and we are looking forward to more. My name is Nelson from KNH Research. I would also like to thank all the participants and for joining and also participating in this talk that we've had this afternoon. We will be back next Tuesday, continuing our cervical cancer series. And on 27th, we will be looking at the diagnosis of cervical cancer. So be sure to join us on that, and you will receive your normal reminders and notifications through your email addresses. Thank you once again. Do have a wonderful afternoon.